Good afternoon. Let me welcome all of you to the monthly CRTM lecture. So this is a regular event. Every month we have a lecture from CRTM by a guest speaker. Today's guest speaker is Dr. Duminda Yasaratne. He's a consultant chest physician and a senior lecturer in the Department of Medicine. He's going to talk about a very common topic in the world as well as in our country, important topic, tuberculosis. Is the subject or the disease that all the doctors should be well thorough about it. So over to you, Duminda, for the presentation.
Right. Yeah. Thank you very much, sir, for the kind introduction, and also thank you to Professor Kularatne and also Professor Dalugama for inviting me to do this talk. As Professor Kularatne mentioned, yes, it's a very important topic for physicians who are working in this part of the world. Tuberculosis it's a must that because it's also called the great masquerader. So because it can mimic so many other illnesses, and also it can involve many systems. So with that, I would be focusing mainly on different aspects of TB and what are the challenges, especially we encounter in this part of the world, especially in the tropical countries. So I'll be quite not very elaborative talk, but briefly and a bit of a summary. So just a background, sorry about the color there. So TB in Sri Lanka, that was in 2014. The estimated incidence is 66 per 100,000. So 66 is, we're not too bad. We can be actually happy about that because the low incidence is considered 10 per 100,000. Then above that is medium to high burden. The top countries, the top 30 countries are taken as highest burden of TB in the world. So that would, the high burden would come about 150 per 100,000. So we are 66. So that is especially considering our neighbors. We are in a quite advantageous position. However, the WHO estimate is around 100 per 100,000 for Sri Lanka. So all this time they have been like forcing us to do more screening, more community screening, and to find that 100 to 100,000, 100 per 100,000. But then even after so many attempts, we are at this level. So I think our incidence is quite low in the sense not low, but it's a medium burden. But among the medium burden also we are in the lower end, 66. So that's quite good. And more importantly, we have very little or even almost negligible resistant TB in the community. So that's a very big advantage. We will discuss as we go on. So usually we diagnose about 9,000 cases per year, 9,000, 10,000 new TB cases per year. So this has been a very ancient disease. In ancient Egyptian mummies, they have detected the skeletal TB. And also during this 3rd to 4th century before Christ, TB has been very rampant. That is skeletal TB and also scopuloderma or the skin TB. So TB has been a very major issue. So there have been sculptures of spinal TB like that. And also these great personnel who had lived in the same era for 3rd to 4th centuries before Christ. The Hippocrates has named tuberculosis initially as I think we call it thesis, PHTHISIS. That's a Greek term for consumption. So the same as Ksharogia, we call it Kshaya because it's consumed. It consumes the person. So that's the same idea, that the initial idea. So I think our name, that Ksharogia, has come directly from that sense. Aristotle, he's a philosopher. He's not a physician, but then he's considered as one of the pioneers in evidence-based medicine because he's a teacher of logic and philosophy, and his teaching was the basis for or the foundation for the evidence-based medicine. And also he thought that this TB was contagious at that time, where people thought these are superstitions, God's diseases. But then Aristotle said, no, it's not. It is contagious. You get it from one person to other. So that's how it has progressed initially. TB is not a tropical disease. It's a global disease. It's a global epidemic. But it's highly prevalent in the tropics because it's an opportunistic disease of poverty, overcrowding, and malnourishment, which you see very commonly in the tropical countries, and also which also have poor health infrastructure, and also economic disadvantages and political instability. So most of the things, as you see, that you can see much more common to even to Sri Lanka. Right. So if you see the world map of tuberculosis, you can see it here. So it's mostly the darker areas are in the tropics. So even though it's globally distributed, you can see that the most burden is in the tropics. In fact, 80% of the global TB burden is carried by 23 countries, which are nearly all of them are in the tropical region. And 60% of them are in just 6 countries. So what are these 6 countries? Sorry. Yeah, it's here. Okay. So these are the 6 countries that carry the most, like 60% of the TB burden. And you will see our neighbors are there: India, Pakistan, China, Indonesia, just surrounding us. So we are happy. Like, not very happy, but we can be proud of our TB control. But there's a lot of improvement that needed. But still, people have this is all the results of very hard work of several organizations and our doctors and a lot of people, and also in Nigeria and South Africa. Okay. So in the next, I think about half an hour, I will quickly go through, like, I'll touch upon this, what are the mimics of pulmonary TB, especially relevant to the tropics, and also briefly discuss about CNS, the neuro TB, and lymph nodes, and we'll touch upon this ocular and skin, depending on the time we have. Because these are the commonest manifestations of TB. We have about 60% of pulmonary and about 40 to 30% of extrapulmonary TB each year. So extrapulmonary TB is also on the rise, with immunosuppression and other, the differences in our socio-demographics. You see a lot of these extrapulmonary TB. So I'd like to thank Menuka also for helping me to prepare the slides that I will show you in the next few minutes, because I had to, do it within a couple of days. So this is TB. So TB can occur in many different ways. It can be, you can see here, fibrocavitary consolidation or miliary mottling, or it can be like an abscess. So there are different ways of presenting. Or it can be simple consolidation, or sometimes you see post-primary TB where you only see fibrotic scarring. So there are different manifestations depending on the stage that you see these patients. So the most common differentials would be like chronic or like poorly responsive bacterial infections, or bacterial chest infections, that always you try to differentiate from tuberculosis. Then there are other chronic infections. Some few of chronic infections now I'll be discussing. Melioidosis is not alien or not uncommon in this part of the world, and you see that distribution is mainly in the Southeast Asia and the northern Australia. The majority, the highest area is that, but also it is prevalent in some other tropical countries, as you can see here. So melioidosis is a so Burkholderia, the organism, it is present in the soil and also in the surface water. So the people who work with soil and water, like farmers, cultivators, fishermen, they can contract melioidosis. And melioidosis also cause, it's a great, like what you call an imitator. It can also mimic several other diseases, including TB. Now, if you look at these X-rays, you can hardly differentiate from the previous X-rays that we saw. So this can also be very, very like TB with multiple cavities, consolidation, nodules. You can see here. Yeah, so these are the people that who can be involved, and also it's a multisystemic involvement. So CNS involvement is common, But we can also get other visceral organs like bone, liver, spleen, GU tract, and also muscles and the skin. So you can see melioidosis also can have multiple facets or multiple manifestations. So that is one of the one disease that we commonly encounter now. Even at any part in the any moment in our ward, I think there are patients whom we suspect TB and melioidosis, so we investigated for these things. The problems would be now the challenges here. What we feel is to get the melioidosis diagnosed. Sometimes it's not easy. Because patients have already got antibiotics, so the cultures are bound to get negative. The gram stains and cultures, you might not get positive results, and also these melioidosis antibodies, and we all know how difficult to get these things, especially in these difficult times. So sometimes you need to treat on clinical grounds, and this treatment also involves weeks of treatment, not just few weeks. It is several weeks, and that there are a lot of cost for the patient and also for the health system. So that's one challenge we have. Invasive fungal infections, again, they are prevalent in warmer areas, warmer climates. They are this Asia, the India, Sri Lanka, and the other. You can see here they are white, not because it's not that you don't get fungal disease in Sri Lanka, because you don't have data. We are not done enough studies here, but it is very prevalent in our part of the world. So there are different, as you can see, there are very different types of fungal infection: histoplasmosis, coccidiomycosis, aspergillosis, blastomycosis. And if you see the pulmonary involvement of this fungal, again, it's very difficult to differentiate from TB. All these are chronic infections, low-grade fever, loss of appetite, loss of weight, chronic consumption, sometimes very difficult to differentiate. And also they are immunocompromised patients. Again, they can have fibrocavitary or abscess-like pictures. This is aspergillosis. This is invasive aspergillosis, and this would be aspergilloma in a previous tuberculous cavity. So again, this would mimic a tuberculoma also. So it's again difficult to differentiate. If you can look at this lower two pictures, this histoplasmosis, that is miliary histoplasmosis. It's identical to miliary tuberculosis. So you cannot clinically differentiate. Blastomycosis commonly can present like abscesses, but also can be consolidation, lymphadenopathy, and sometimes solid masses, even can mimic malignancies. So these are all like interrelated. So you need a lot of effort and diagnostic facilities to differentiate. So I think in Peradeniya we would be very happy with our microbiological team, because we have these fungal studies in our department, in our faculty, but it's not the case for most other centers in the country, because doing fungal studies, even in the private sector, it's very difficult. So we need a lot of support from the microbiology people to diagnose these cases. So that's again a challenge that we face when encountered with fungal diseases. So when we diagnose, we go by the HRCT characteristics, that air crescent sign that you saw previously. Sometimes we look at these halo signs in the fungal diseases, but they are not specific or pathognomonic. So commonly we go for treatment trials. We treat for the infections, but if not responding, we try to give a trial of antifungals and see. As per the specific IgG, histoplasma, these serological tests, fungal staining cultures, galactomannan tests, all these would be helpful, but not very commonly or very readily available to treating physicians. Filariasis, the lymphatic filariasis, it is a tropical disease, as you can see here. So it's commonly in the limbs, in the peripheries, lower limbs, but also this microfilaria of these organisms, the Wuchereria and the Brugia, both organisms can cause what's called tropical pulmonary eosinophilia. It is a tropical disease in the lungs. So basically, the patients who are living in endemic areas for lymphatic filariasis with a peripheral blood eosinophil count of more than 3,000, with elevated serum IgE levels, because it's a parasitic infestation, and also with antiviral antibody positive, and with chest X-ray infiltrate. So with this diagnostic criteria, we can diagnose tropical pulmonary eosinophilia. If you diagnose them early, you will see in the chest X-rays there will be fleeting shadows, transient shadows in the chest X-rays, but in later stages it would be more fibrotic lung diseases. Once you get into that stage, it's very difficult to differentiate, because there are a lot of fibrotic lung diseases. and lymphatic, the tropical pulmonary eosinophilia would also lead at the end stage fibrotic lung disease. But it's very important you diagnose them early, where you can treat them. So initially it will be very subtle changes with transient migratory shadows, but later on you can get these perilymphatic nodules, multiple randomly distributed nodules, and later on the fibrotic scarring. So again, in the filariasis, again you need to diagnose with the serological test, sometimes which is not readily available. You have to depend on the private sector, and not every patient can afford that. So sometimes we tend to miss these diagnoses. Another eosinophilic lung disease would be Loeffler's syndrome, or the simple or the chronic pulmonary eosinophilia, which is caused by these larvae of Ascaris, or the hookworms. So the hookworm disease, I'm not sure whether we can classify it as a tropical disease, but it is a disease of the poor nations, which are mostly tropical in geographical sense. So you can see the areas where you see a lot of Ascaris infection, and simple and chronic pulmonary eosinophilia, or the Loeffler's syndrome. There's a triad. They say there's again eosinophilia, pulmonary infiltrates, and wheezing. So the pulmonary infiltrates would be again like initially transient, but they would be mostly peripheral. That would help us to differentiate from tuberculosis, because tuberculosis you get predominantly apical changes, whereas here it would be mostly peripheral. We call it reverse bat swing. Like bat swing appearance you get in ARDS, but this will be reverse, or the negative image of the bat swing appearance in chronic or simple pulmonary eosinophilia. So that would help us to diagnose. So here you have to do this again, the serological testing, sometimes not available. NTM, non-tuberculous mycobacteria, is a global phenomenon. I just mentioned it here because that is one of the main underdiagnosed and what you call that neglected illness when you consider chronic chest infections. Because all patients who are getting a sputum AFB positive, we treat them as tuberculosis. But to find that majority of them can have NTM or coexisting NTM, the combined NTM and TB. So I'll show some evidence that we have. So there are a lot of non-tuberculous mycobacteria, the avium intracellular complex, Kansasi, Sanopi, Malmonense. So there are several different types of non-tuberculous mycobacteria. Like there are hundreds of NTM. So the treatment is different from TB. So we need to diagnose this, and this can sometimes patients do not respond to anti-TB treatment. Then we have to think about NTM. Just a small study that we have done in Kandy. So where we just looked at the bronchoscopy samples to see that about 25% of patients having undiagnosed this NTM in their lungs when they get sputum positive. So it's very difficult to diagnose, but a good microscopist would be able to say by looking at the AFB staining that usually the AFB thin and long organisms, but in that is TB, but in non-tuberculous mycobacteria they are short and thick. So that is, if you are experienced, we might be able to detect that. And the cultures also, they are most of them are fast growers, whereas TB take about 8 weeks. NTM sometimes within 2 to 3 weeks they come. Again, another study in Kandy, they have found in BAL positive bronchoalveolar lavage positive patients, about 11% of them were positive for NTM or non-tubercular mycobacteria by gene techniques. So that was this was quite it was published in several presented in several forums. So this is a quite interesting study, and it's very important that we need to look into these things. So it's about the pulmonary tuberculosis. So, and the challenges, some of the challenges we face when we encounter these patients. What about the CNS, central nervous system tuberculosis? It's one of the catastrophic manifestations because you get a lot of long-term sequelae with central nervous system TB. So the TB, meningitis, tuberculoma, spinal TB. So they all can lead to chronic disabilities, and patients can have very poor quality of life if we are not treated them promptly. They carry a high mortality rate of about 15 to 40%, and also permanent neurological deficits in about 25%. when you take TB meningitis, so now we all get in our wards we get a lot of patients with meningitis. So every at any point of time you get 2 to 3 patients in each side meningitis. Or we treat them for meningitis with clinical diagnosis. So TB meningitis is a chronic meningitis. So if the patient come with very acute and very severe headache, acute meningitis, very short history, it's unlikely to be TB. It's a chronic illness with a 2 to 8 weeks prodromal period, and where then the patients get all these constitutional symptoms: malaise, anorexia, fatigue, low-grade fever, and also patients can have a lot of complications. In small children, there can be lethargy, irritability with poor feeding and poor development. They can have cerebral edema, obstructive hydrocephalus, and cranial nerve palsies. So very important, because TB meningitis is a basal meningitis, and when you do the CTs, MRI scan, you get basal meningitis, basal empyema we call them, and that with that they can get cranial nerve palsies. That's very more common than in bacterial meningitis. Also in fungal meningitis, you can get these cranial nerve palsies. They can have periarthritis, thrombosis, and they can have infarcts also. Hemiparesis, SIADH. So all these complications can be there, and we have seen patients who they become bedbound for the rest of their life. So it's an illness which have very catastrophic sequel. So we have to treat them and diagnose them very early. So one of the main findings would be CSF appearances would be clear, whereas in bacterial meningitis it would be more cloudy, but that is not specific. Opening pressure, again, pressures would be high. Now I have another chart, next slides, I'll discuss that also. So leukocyte, the white cell count would be moderately high, not very high. Lymphocytes more than 80%, so it's mainly lymphocytic. But be mindful that in very early stages, TB meningitis is neutrophilic. At the onset, it is a neutrophilic meningitis. But when it comes to the second week, it becomes lymphocytic. So usually by the time we diagnose or we investigate them, when we do the CSF, it will be lymphocytic. But occasionally we can find neutrophilic patients. But the important thing there would be there's no persistent neutrophilic meningitis. So that's the importance of repeating the CSF after about 10 to 14 days. If you suspect TB and if it's initially neutrophilic and you are treated for pathogenic meningitis, but if the patient is not improving, we might repeat the CSF to see whether there's any persistent neutrophilia. By that time, if it is lymphocytic, then you have to think about TB. Partially treated pathogenic meningitis can become lymphocytic, but it would be usually 50-50 or maximum about lymphocytic, usually around 50, but maybe not more than 60. But in TB, it could be more than 80%. So that would also help us to, come to a diagnosis or to differential diagnosis. So proteins would be moderately high. Protein would be high. Sometimes it's very high, like it's usually 0.45, but it can go above 100 and sometimes 200. It's very high. And then glucose will be very low, less than 1/3. So this would try to demarcate the different types of meningitis: viral, bacterial, fungal, and TB. You can see here the appearances cloudy. It can be cloudy in both bacterial and TB, but viral it should be clear. Fungal, of course, it is again cloudy. So there can be a lot of fibrins. White cells in pathogenic bacterial meningitis is very high, 50,000. Whereas in TB, it's moderate, it's fungal moderate, and it's low in the viral meningitis. So sometimes you can get aseptic meningitis even in TB with so mainly you see high proteins, but the cell counts are very low. So that can happen in TB meningitis also. So white cell type, it's lymphocytes, and it's usually more than about 80%. And these things, they don't come up to that high level. So it's about 60%. And it's neutrophilic, but then there are in the small print, I think they say in syphilis, listeria, and there are some other few bacterial meningitis where it can be mostly lymphocytic, like 50-50. But otherwise, it will be about 80% neutrophils here in the bacterial meningitis. Proteins will be very high, 1.5 in both. It's around 1 in bacterial, more than that in TB. Fungal also, it can be very high, especially cryptococcal meningitis. They can have very high CSF opening pressure and high protein contents. In viral, it will be like very marginally high, around 60. Glucose, normal in viral and low in both fungal and bacterial, but very low, less than 30% in TB. the opening pressure, it's be high in most of the things except in viral. So that would help us to differentiate, but then you can see none of these are pathognomonic. So you always need to, apply your clinical senses and all the things when interpreting. So sorry, it's the same. So in our settings, if you don't get cultures are not positive for bacterial meningitis because patients have sometimes they have taken antibiotics. Then you go for a clinical diagnosis of meningitis. It's neutrophilic, yes, that's good. Sugar low but not very low. Okay, it's again supportive of my bacterial meningitis, and they fully recover without any antibiotics or without any anti-TB treatment. So you're happy. So you can retrospectively diagnose them as bacterial meningitis, and then you can, that's the end of the story here. But if they do not respond to anti-TB treatment, then they have these other features. Sometimes you do CTs and they show basal enhancement. That's called basal empyema, basal meningeal enhancement, with sometimes with cranial nerve problems. You might start anti-TB empirically. That is happening in our patients. We also do other testing, microbiological CSF cultures, gene expert. Now we do, but all of them have their limitations. We might start empirical anti-TB treatment because we don't want the patient to go into chronic sequelae, which are very debilitating. Cultures, they have a good deal if you take a good volume, but usually we take about 1 ml because for practical purposes. But in our patients, we don't see much culture positives, maybe about 30-40%. But it can be, and especially if you inoculate it to the culture, liquid culture medium at bedside, that would carry a higher positive yield. That is same for the pleural cultures as well, but specifically for the CSF cultures. Now we have this nucleic acid amplification, or the PCR techniques, what is available in the government sector in all chest clinics. It's called Gene Expert, which is a good test, but the sensitivity is around, can go up to about 70%, but not more than that, 7 to 75%. It has a very good specificity. It can confirm CNS-TB, but cannot rule it. So sometimes we get Gene Expert negative, but still we go ahead with anti-TB treatment if everything else fit to the diagnosis. And the other good thing is, unlike AFB and culture, because if you start treatment, the culture is going to be negative even after 1 or 2 doses of treatment. But even after 1 month of treatment, Gene Expert can be positive because even the dead bacilli can mount a positive response. And also with the Gene Expert, we can diagnose the rifampicin resistance, because it is that specific genetic sequence they check in the Gene Expert, which is encoding the rifampicin resistance. So this is very important in countries where they have primary acquired community acquired rifampicin resistance. If you have a lot of resistant TB in the community, because what we do is we do just sputum AFB, we don't know what is the resistant pattern of the TB, we just start the sensitive normal regimen. But in other countries we can't do it, especially in India, China, they have to check for resistance before starting whatever the anti-TB regimen. So we are, again, because of our low incidence, we have an advantage here. Adenosine deaminase, very commonly we do it in pleural, and it's quite sensitive for pleural tuberculosis and specific with a good negative predictive value, and it is quite clinically helpful. But for CSF, it has its limitations because a lot of other infections like bacterial meningitis, you can see here CMV, cryptococcal, lymphomas, malaria, brucella, all these things can give rise to a very high level or sometimes a negative positive result. In pleural, you make sure that you are excluding an bacterial empyema. So if it is not neutrophilic, if it is lymphocytic, and if it is ADA positive, because you don't get these cryptococcal and lymphoma, those are less likely in the pleural environment. So ADA would be quite reliable, but in CSF, it has its limitations. So we discussed about the CT brain. So there will be basal meningitis, and also you can see these tuberculomas, small tuberculomas. So it's important that we do a CT, and sometimes MRI would also be helpful, but don't forget the chest X-ray. 50% of patients with CNS TB would have some evidence of TB in the chest. So that would be very anecdotal evidence that we might be able to guide our treatment. So So basically, when we are coming to the CNS TB, we are thinking about bacterial TB, bacterial meningitis, and viral meningitis and fungal meningitis. But there are a few other less common things that I just noted here. Cerebral malaria, again a tropical disease. We don't usually find it as a problem because the patients are they have clinical characteristics, very high grade fever and the classic patterns. But some, because cerebral malaria is usually very severe, you get under 5 and also under 15, up to about 15 years of age, you can get severe illness. But after that, it can be less severe. So in less severe form, sometimes it can mimic tuberculosis. That's what they say. Because that also, cerebral malaria also can come with all these clinical syndromes: drowsiness, confusion, disorientation, delirium. So sometimes it's, if they don't have the classic patterns, the history might be challenging to diagnose. So thick and thin films we have done, and also the anti-plasmodial or anti-malarial antibodies. But I think, if, as far as I can remember, the tests that we have done became negative, so we didn't have a confusion there. But it can be it's always important that we consider these things as a possible differential diagnosis. Here, the proteins and the opening pressures, everything CS studies would be largely normal. Typhoid encephalopathy is not something that we commonly talk about, but it is not uncommon in our part of the world, as you can see in this thing. So it is again something that we can, keep in our mind. Usually during the second week of fever, they get the meningism and the meningeal, and the features of meningism. So look at the classical pattern or the features of typhoid, including the stepladder pattern fever, the raw spots, quartered tongue, doughy abdomens with splenomegaly, initially constipation, and later developing diarrhea. So these are classic teaching that I'm sure that we all have gone through. Headaches, delirium, confusion. So it's important that we do the cultures, and the cultures would be mostly sensitive for salmonella. Serous cultures, blood cultures. So that would guide us towards the correct diagnosis. Also, we can do other genetic testing like PCR, ELISA, serological testing would help. Japanese encephalitis is mainly in the Southeast Asian and the Asian part, East and the Southeast part of the Asia. Again, we don't talk about being in the mountains, because even if you take the Sri Lanka, it's mostly in the flat areas or the coastal areas. But now, of course, it's part of the national immunization program, if I remember correctly. So it's there, even though viral meningitis, encephalitis, we mainly think about herpes and maybe then other viruses like adenoviruses, but Japanese encephalitis is also there. But I think our viral panel, when we send for CSF viral panel, it includes Japanese encephalitis. So that is again, it's a mosquito-borne disease. And sometimes it can have a very chronic indolent course, where patients will have behavioral abnormalities, and sometimes they are misdiagnosed as psychological or psychiatric illnesses. So that it can have different, phenotypical presentations. So we have the Culex, the mosquito, and the host vectors, and the secondary hosts. So they present again with typical features of meningitis, disorientation, coma, seizures, and can be quite very dramatic disease. So they have again the serological testing and ELISA, and also genetic testing with PCR panels. So most viral panels that include JE, in addition to herpes and other types of viruses. Listeria is not uncommon. So it is, I think it's common. It is there globally. But we get it in immunocompromised patients, mainly elderly immunocompromised patients, including liver disease, renal disease, organ transplant, chemotherapy patients. But don't forget pregnant ladies, pregnant women, where you get listeria and they can have a lot of complications. It's a foodborne disease with milk, and also the foods of animal origin can get contracted or infected. We recently had the gastroenteritis. The whole batch of students coming with who have gone to Siripada with the listeria gastroenteritis. So that can be common. That can be seasonal or like endemic. Then you can have this hepatosplenomegaly, the visceral infection. They can have bacteremia, they can have cerebral, the meningitis, listeria meningitis, and especially in the pregnant ladies, there can be vertical complications. So the clinical presentation would be like any bacterial infection, but they would have lower CSF white lymphocytes. The lymphocyte count can be a lymphocytic meningitis, but that would be about 50-50, not very high lymphocytes, about 50%. So the blood cultures would help. So that would be gram-positive cocci in listeria. Yeah, I think gram-positive cocci. ADA would be negative. They would have a lymphocytic picture where ADA would be negative. So that would be help. Direct visualization can be done in wet mounts, and CSF gram staining and culture would give us a diagnosis. Leptospirosis, of course, is not uncommon. It's very common. We don't get much neuroleptospirosis when we compare with the renal, liver, and the pulmonary manifestations. But again, occasionally there can be complications with neuroleptospirosis, which can be confused with the CNS TB, because sometimes it can have a chronic nature. So they can have in leptospirosis all these things: aseptic meningitis, encephalitis, cerebralitis, myelitis. So those are immunological mediated phenomena, like the respiratory complications. So it's again so leptospirosis is a multi-system involving disease. So CSF leptospirosis for PCR can be done if it's available. So CSF analysis would show an aseptic meningitis with elevated proteins with very low, the cell counts would be very low. Sometimes there can be mild neutrophil leukocytosis. Then again, tuberculosis can come as isolated, like not meningitis. Without meningitis, they can come just as tuberculomas, like mass lesions, space occupying lesions, which can be confused with a lot of other things like bacterial abscesses and malignancies, primary and secondary brain tumors, then toxoplasmosis, cerebral lymphoma. So all these things can be considered as differential diagnosis. So usually you go by the supportive evidence and sometimes with treatment trials, and of course brain biopsies can be helpful if they're in a place where they can access it. Okay, that's about the CNS TB. Very briefly, I'll touch upon the TB lymph nodes. That is the commonest extrapulmonary tuberculosis that we get in this country, or even like typing globally. So TB lymph nodes can be isolated lymphadenopathy, or it could be part of the pulmonary TB. So still they can, or the extrapulmonary TB. So with other pulmonary and extrapulmonary tuberculosis, they can have lymph nodes. So usually it's cervical, but inguinal, axillary, mesenteric, mediastinal, and so there can be all types of lymphadenopathy. So of course, when it's cervical and axillary, you can come to diagnosis. But when these are visceral lymphadenopathy, sometimes we have to go for these mediastinoscopies and abdominal. They have to do cameras and they have to do laparoscopies to come diagnose. Again, we have, with the help of our surgeons, we have a good team, surgical team. So we are doing these things. So we have good support there as well. So the lymph nodes can be initially reactive hyperplasia, which then at the stage 2, they can coalesce together and go to, because of the periadenitis, they go to the classical mapping lymphadenopathy that we can clinically diagnose them as TB lymph nodes. They are non-tender matted lymph nodes, whereas in lymphomas, you get isolated rubbery lymph nodes. Sometimes they are painful as well in leukemias. Usually TB lymph nodes are painless. Then they become cold abscesses. Cold in the sense, when you have malignancies, they are hot because they uptake all these isotopes when you do isotope scanning. But TB, it's a cold abscess. Then at the 4th stage, they can have what is this called a clustered abscess. So they can go into the deep fascia. So these are the fascial layers. They can go invade into the deep fascia where there's a large area there, and here is a small area that you can see. So it's a clustered abscess, like a buttonhole here. So you can only see this area, but be mindful that there's a lot of remaining tissue inside. So ultrasound will be helpful, and then they rupture and they cause a fistula or the sinus tract formation. And this can be quite disfiguring and scarring. So I think ideally we have to diagnose them before they go into these cholestatic or the at this stage, and then we have to do aspirations and biopsies, sometimes resections as well. So it can be quite disfiguring like this. So they are called scrofula or the scrofuloderma. FNAC and excision biopsy all would be helpful to diagnose. So we can send all these samples of microscopy, TB culture, gene expert, or the PCR techniques. But usually what we see is that people take the sample and they put it into the formal saline, and then of course we cannot do the microbiological testing. So we have to advise the surgical team that we need the sample in the normal saline as well. So yeah, we can do the all the microbiological tests as well. So ultrasound, CT, all would be helpful. So toxoplasmosis is again a disease which is not uncommon in the tropics. I think the distribution would also depend where the cats are, because you mainly get it from cats. So it's toxoplasma. It's a zoonosis, and it can affect again many parts of the human tissues, human body. So these contaminated fecal matters from the cats can contaminate the foods, and they can be ingested, and the people can have toxoplasmosis, including muscle toxoplasmosis, brain toxoplasmosis, and lymph node toxoplasmosis. So it's again a multi, can have disseminated disease. Then there are secondary vectors as well. So human, cattle, birds, rodents, pigs, all can be intermediate hosts, but mainly it will be cats. So they will have swollen lymph nodes, constitutional symptoms, headache, fever, blurred vision, because they can have choroidoretinitis. So toxoplasma retinitis would be they can lead to blindness. So you can diagnose them early. Confusion because they have cerebral toxoplasmosis. So you have to biopsy, and then you have to specifically do for PCR testing. Again, we are lucky that we have in our pathophysiology department, they do this toxoplasma PCR testing, but it's not available to all parts of the country. So it's there. Cat scratch disease, we don't talk about these things much, but just out of interest, it's mentioned here. It's there like globally. So Bartonella is transmitted by this cat saliva, and again they can have very painful lymph node. The last time I saw a patient was during the final year when Professor Nimal Sennaik diagnosed a patient. I don't know. After that, I have not seen that lymphadenopathy with cat scratch disease. Yes, so the history is important. So we have to think about these things. Right. So this is again about the cat scratch. I'm not going to go into detail about that. So they can have again disseminated disease. Okay. Ocular TB, another type of TB. This is number wise. This might not be very great, very high numbers, but again because of the complications, people can go into blindness. So it's a very important disease. So when you work in the chest clinics, you get referral from the eye and the skin very commonly. So eye unit, they all these coronary arteritis patients, they would send us to exclude TB. The eye involvement can be very like there can be multiple eye involvement. It can be conjunctivitis or granuloma. So it can be flictonular keratoconjunctivitis, which is mostly an allergic response. Then tubercular scleritis and keratitis and iridocyclitis. So this is chorioretinitis, and this is what is called the flictonular keratoconjunctivitis. So these things would not have much complications, but here the chorioretinitis would have very grave complications leading to blindness. So you have to treat them. So the diagnosis again is a challenge. So we have to think about toxoplasmosis, syphilis. I think there's a list here: syphilis, toxoplasmosis, toxocariasis, sarcoidosis, and also autoimmune vasculitis, SLE, and other connective tissue diseases, and CMV, choroidoretinitis, and HIV. So all these are possible differential diagnoses. So ideally, they say that we have to do a retinal chororetinal aspirates and do this posterior chamber fluid for diagnostic testing, which is very difficult to get. So we don't have these facilities. So sometimes, so most of the time, we end up treating on a trial basis. So it's a challenge again. I have not mentioned about skin TB again, because especially as I worked at Anuradhapura, this cutaneous leishmaniasis is a real problem there, that we had to diagnose leishmaniasis from differentiated from TB, and then there are other skin diseases like sarcoidosis that again can make it a diagnostic dilemma. So with that, I think given the given time, I think we can stop now. So TB free Sri Lanka. So there's a TB day every year March. In every year March, there's a TB day. So there are a lot of activities going on for public education, the school education. So there are a lot of activities going on. So hopefully with this, all these things that we would be able to curtail the disease. So we have strong points. We have island-wide TB network, and we have very dedicated and a very well-trained team. We are practicing directly observed treatment strategy with some limitations. And very importantly, we have very low cases of community-acquired resistant TB, which is a very, very good advantage for us. This is not a strong point, our cough etiquette. We have to improve our public education. So we have failed because of poverty, poor social status, our climate. Yes, hot climate, which is very favorable for TB. Limited diagnostic facilities, especially in this part. Now most of the things are not getting replaced because of the financial crisis. And our inward facilities are also not enough, and public awareness, stigma. So there are a lot of things that we have to improve. Thank you.
Thank you, Duminda, for that elaborative lecture. I mean, you made this huge topic, right, into a very understandable presentation. As you said at the beginning, TB could mimic anything. So you gave a extensive list of differential diagnosis under different categories of TB. So once again, thank you very much for that interesting presentation. Now the question time. If you have any questions to ask and verify your doubt, is the time now. I'll start then. I mean, this gene expert, what's the availability of genes expert in Sri Lanka? And I mean, how long it will take actually to get the results and the process of testing? And you mentioned about the sensitive and specific, no doubt about those are my concern about gene expert.
So the good thing is that gene expert is now available in each province in the country. So it's available at the chest clinics. So I think it's very important that all the practicing doctors should know, because now we have to get. Now we have a lot of sputum centers in each district as well. So if you ask practicing general practitioner, what is your nearest sputum center, I think that is something that every general practitioner should know, because that is not there. So I think there was a campaign that there was a list printed and was given to all the GPs, because to improve that, all the patients with chronic cough to be centered. So likewise, gene expert is available only in the district chest clinic. So there are 9 district chest clinics. So in all district chest clinics, this is available. The time-wise, the test will only takes about only 2 hours, but then for the reporting and everything, it will take about 2 days for the sample collection, and finally we get. But if you are really in a hurry now, most of our patients, we have a good communication with our Bogambara people, and sometimes we think about a day. If they can do it, they will get us usually by the next day. We sometimes, if it's really urgent, we can get it. So we have done that. But within a week, of course, I think really we can get the results. So it's very good. Now the WHO actually, their recommendation is for all community acquired, like tuberculosis, do a gene expert, which we cannot do because of the large numbers. But as I said, in the countries which have a very high resistant TB in the community, our resistant TB is usually we get among patients who are being retreated because of the drugs that we give. They acquire resistance, and they are, when we try to retreat them for a second episode, they are found to be resistant. That's a acquired or a retreatment resistance. But in the community, so unless they go and spread the disease, so that's why. So that's a problem with this treatment. So that's why I think it's very important that we should be very careful when we start anti-TB treatment, because we don't want to stop it once we start it, because we are starting because there's a possibility of TB. Then that possibility is there, even though when we come to a second diagnosis, still the possibility is there. So if we stop it within a few weeks, then we might inadequately expose the patient to anti-TB drugs, and then we might create resistance. So that's going to be a problem. So once you start it, you generally, now earlier there was a concept called anti-TB trial. We give for 1 month and see, but now the campaign does not recommend that. So if you start it, do the full course for 6 months. That's the current recommendation, unless in exemplary situation. So DNXPT is available. It's a good test, and it can also detect the resistance TB as well. So yeah, it's about it.
Thank you, Duminda. Any questions from the audience? So you maybe have questions.
Still, in the previous part, but I was told that was discussed. Very interesting lecture. Thank you.
Thank you.
I think the lecture should be given to almost all the specialties, because it won't be a challenge to you when it comes to, if it comes to you. Problem is, as you very correctly said, like the GP is not coming to you. So then we have to expand this to almost all the other specialties, including the GP. And then this as a differential diagnosis should come to them, not to go for a trial and then leave it as an exclusion diagnosis.
It is very correct. Actually, there may be delays of diagnosis because these different presentations at different level, and they're delaying even considering as a possibility. So patients are get stagnant in different places. Yeah.
There was one study, sir. There was they have looked at the delays in diagnosing TB. So there's a patient delay, but more than the patient delay, there's a delay once the patient comes to the first doctor, first contact doctor. There's a delay. There's a lengthy delay there.
Medical registrars, SRs. I mean, you must be having questions.
So one thing I know, we have the protocol in the wards. Now all patients whom we do CSF, if it becomes like lymphocytic, it's not like very clearly pyogenic meningitis, we send for TB PCR, because usually most of these patients we have noted that after some time we have the doubt of TB. So all CSF TB, CSF samples, they would, the gene expert, they would not for any samples. That's again, I couldn't answer, I forgot to tell that. In children's they would do, because those are precious sample, very difficult to get. So in children's they will do without questioning. All CSF samples they would do without questioning, because that is again the precious samples, and there are a lot of consequences in CNS TB. Then of course urine, pleural, they would question us why do we really need this. So we have to justify that. But yes, with justification we can send, but CSF, yes, we can send. So again, for our team that we have already, they are aware of that, and we are doing that, and that's, I think that should be the practice, because yeah.
Is there a rise still in these days? I may have missed your prevalence spoken, I don't know. Because now, if I remember right now, there was some problem with this vaccination programs and aspects in the recent past, very near past. So the pediatric population, I'm not really sure. So is there anything for us? Is there a rise?
Yeah, we have. I think I'm not the best person, because I don't now work at the chest mixer. But yes, I think one reason was that patients used to come to hospital. Now the access to the general practitioners was limited during last time. So we saw a lot of cases in the hospital, because patients used to come and get admitted. But I'm not very sure about the number wise whether that has gone up. But we saw a lot of patients with TB. Yeah.
Then coming to this non-mycobacterial TB, right? Do you see that commonly in the tropics or in the other countries? I mean, do you think what's your knowledge about it?
I think it's a global thing, sir, because when we go to these conferences, everybody is talking about NTM, and there are guidelines for NTM like in the other temperate countries as well. But anyway, this TB with the warm weather, you get more infection. That is why probably it is considered a tropical, it has a tropical prevalence. NTM also, I would say that would follow the same pattern. And only thing is that our areas, they are blank because we don't have the results. We don't have the research and the data. But I think it is more prevalent in this part of the world than in the the developed countries.
In your study, actually, you showed that you found about 30% of.
Oh yes, about 25% among the TB positives. That was from the culture evidence. Yes. Then we had some doubts about that, but then that is why after that they did the study with the IFS people where they had all the facilities for gene sampling, and their figure was 11%. So among all, that was also like, so that's 100 patients with smear positive TB. 11 have either coexisted or primary NTM infection. That's 1 in 10. So I think it's quite a big number.
So what happens to those patients actually?
So usually what happens is they don't respond to anti-TB, and then they become like they are sputum positive again after 1 month, 2 months, 3 months. They are positive. So then ultimately they will be diagnosed, and then their treatment course has to be changed. So they need a lengthy course with some different drugs. So that has to be changed. So yeah.
Hey,
And
thank you.
sometimes they develop bronchiectasis and other complications. So and lung fibrosis. So that also there. Thanks.
Any questions? Anyway, when you come to TV, physician like me have hundreds of questions, right? But this is not the time to ask us. You have to give chance to everybody, right? Anyway, absence of any more questions, I would like to thank Duminda for accepting this invitation within very short time, right? And sharing knowledge, right? In this important topic. I would say it's important topic, right? Everybody must know about it, right? So on behalf of CRTM, again, thank you, Duminda, as well as to the participants, especially our dean. Every time she's there.
Can I just suggest something that,
Yeah.
In the faculty website, you can open up the CRTM like an icon, and you can have all these lectures there. You are free to.
Yeah, we have already.
Yes,
Yeah.
So, but the lectures are. I know that is yeah, that's the thing.
Yeah.
We will have the lectures
Yeah.
also, and then also.
So you can link into the faculty website.
Yes.
Yeah, I know that we did the notices, but the lectures. If we are okay with that.
Yes. Yeah, no, that's fine.
Dissemination of knowledge.
Yes, thank you.
Yeah.
It's recording.
So you can
Link it to the yes. I say so. I'd like thanks again to Sir and Chamara for inviting, and all the participants for patient listening. Thank you.